angiography has been becoming more popular over the last 5 to 10 years for a number of reasons. It has several advantages over fluorescein angiography. First, it's non-invasive, so you can obtain angiographic level detail down to the capillaries without the risk of a dye injection. You can also visualize the deeper capillary plexuses, in particular the intermediate and the deep capillary plexus, better than you can on fluorescein, which doesn't really resolve those plexuses. And it provides quantifiable data. For example, in diabetic retinopathy, we can quantify the degree of non-perfusion and the degree of neovascularization. On the other hand, it has several disadvantages. One is that it provides a smaller field of view than we're used to looking at with wide-field angiography. There's a number of artifacts. And particularly for pediatric application, there are no commercially available handheld devices. So as I mentioned, OCTA has a narrower field of view compared to wide-field fluorescein angiography. So in adult practice, it's come to be used primarily for the diagnosis of macular disease. For obvious reasons, it doesn't replace fluorescein for the evaluation of the peripheral retina. This is an image of a baby with ROP that was imaged by the spectralist by holding the baby up to the device. And you can see how wide-field angiography shows you more information than what would be obtained by holding the baby up to a typical OCT angiography device, as illustrated by the red square. So you can imagine how in pediatrics we could use typical commercially available OCT angiography devices for the evaluation of the macula, and certainly that's been done. This would be most relevant in older children who could sit comfortably and still for at least a few seconds, focusing on a light source while this image is obtained. And there's some obvious applications: choroidal neovascularization, vascular disease, dystrophies, tumors, and there are increasing research looking at the foveal anatomy in patients with history of moderate to severe ROP. For example, this is a baby, this is an older child with Best disease, typical vitelliform lesion, and a choroidal neovascular membrane visible in the outer retina where there should not be any blood flow. This would be useful for diagnosis because it's sometimes difficult to obtain fluorescein in these children, as well as monitoring as that neovascular membrane regresses with treatment. These are two children with retinal vascular disease. On the left is a child with sickle cell retinopathy, and you can see abnormal non-perfusion in the quadrant here. This was, I don't have this on this slide, but corresponded to inner retinal thinning in this area, and a child with familial exudative vitreoretinopathy demonstrating the typical straightening of the vasculature and irregular vasculature. So you can see this is not necessarily better than a fluorescein angiography for the diagnosis of macular disease in these patients, but it can be done safely without the need for intravenous injection. This is a child with choroideremia, and what you may appreciate is the outer retinal atrophy here, as well as the loss of the choriocapillaris signal. This is a teenager with a hemangioblastoma. You see the typical appearance of a feeder vessel and feeder arterial and venule coming off the superior nasal branch retinal artery and vein. So those are sort of conventional applications of OCT angiography in children. But since children are different than adults, we have to ask the question, do we need to use this technology differently or use different OCTA devices to apply this technology in young children? Anand Vinikar here in India was one of the first to use OCT angiography in ROP by holding a child with ROP up to an adult commercially available OptiView device and obtained these images of what was clinically apparent as recurrent neovascularization. The Duke group has pioneered microscope-mounted swept source OCTA for use in the operating room and published some images as well. However, neither of these methods is practical for widespread use in young children, particularly in the neonatal intensive care unit. So we developed a prototype handheld OCT device that can be used for wide-field OCT and OCT angiography and applied it in the neonatal ICU. These are some of the first images we obtained. This was in a normal adult, showing the capability of the resolution. These images were all obtained in 2 seconds. Notably, we can adjust the size of the image to obtain different areas if we want to include, for example, the disc and the fovea on the same image without changing the size. We can also make it even wider if we're willing to tolerate lower resolution and some motion artifact. So these are some of our first images of using OCT angiography in children. And again, this isn't necessarily better quality than an angiogram, fluorescein angiogram, but it could be obtained in theory on every child that you're screening. Here's an example of a wide field OCT angiography, and I'll acknowledge that there's a lot of motion artifacts. So you could sort of think of this as a poor man's fluorescein angiogram. But again, you could see that the vasculature goes out into zone 2, because here's the corresponding OCT, and you could say there's no neovascularization seen on these images. So how could this improve our diagnosis of ROP? Well, we know that one of the most critical transitions in ROP in terms of leading to visually important sequelae is that transition where you get neovascularization and breaking through the internal limiting membrane. OCTA can see that better than the clinical exam. This is a baby who received Avastin. 2 weeks after Avastin had no plus disease and no apparent neovascularization. However, OCT angiography revealed persistent flow above the internal limiting membrane that either represented still regressing disease or early recurrent disease. In theory, this could be followed over time. This could also be quantified into an area of neovascularization as a biomarker. Remember, in the cryo-ROP days, there was this diagnosis of threshold ROP that suggested to us that the number of clock hours of stage 3 had prognostic significance. In theory, OCTA could quantify that for us in all children. It can also demonstrate non-perfusion. So this is a baby with incontinentia pigmenti who had had several rounds of panretinal photocoagulation for very severe and very posterior disease, who still had macular non-perfusion, which was somewhat hard to see on the angiogram, but very easy to see on the corresponding OCT angiography. Finally, we're learning a lot about the FAZ, the foveal avascular zone in children, especially children with history of ROP. In theory, OCT angiography could help diagnose and monitor, could help teach us about when the foveal avascular zone develops and why it doesn't develop normally in patients with ROP. Finally, all OCT angiography devices have the added advantage of providing a structural OCT as well, and high-speed OCT devices can provide wide field images such as those seen here. This provides objective diagnosis of ROP, and I think we can all understand why, in theory, that would help us all be consistent in our diagnosis of ROP. It could evaluate choroidal volume, macular edema, and photoreceptor development as well as detection of early vitreoretinal traction, retinal detachment. In summary, the technology is evolving rapidly. It has both advantages and disadvantages compared to traditional photography and fluorescein. And we may need to utilize it differently in children or utilize different devices in children. And all of these instruments will require further study to determine clinical utility. Thank you very much.